Roof is professor at Mount Sinai, where he serves as a head and neck oncologic and reconstructive surgeon at their Head and Neck Institute. His skill set includes minimally invasive surgical techniques such as transoral robotic surgery and transoral laser microsurgery, as well as microvascular free flaps. He completed his undergrad at Northwestern, received his MD at NYU, where he graduated AOA, completed his residency at Mount Sinai Hospital, then later went on to complete his head and neck surgery, microvascular reconstructive surgery fellowship at Cleveland Clinic, where one of our current chiefs is going to be at for head and neck fellowship next year as well. Dr. Roof has published nearly 50 research articles on head and neck surgery, though a specific expertise on the role of circulating tumor DNA in patients with HPV-associated oropharynx cancer. And today he'll be sharing the latest updates on this topic and its utility in improving care for this patient population. So thank you so much, Dr. Roof, for being here. We really appreciate it, and we look forward to your talk. Thank you.
Perfect. Well, thank you for that introduction. I'm truly honored to be able to give this grand rounds and to be invited and to talk to everyone a little bit about what we've been doing at Sinai and our experience to date. The title of the talk is Liquid Biopsies and HPV-associated oropharyngeal cancer, the evolving role in patient management. We've all known about HPV oropharynx cancer for a number of decades, and really it's become widespread knowledge in the last 15, 20 years. We all know that they have about a 90% overall survival or excellent survival overall. And there's been a lot of efforts to safely de-escalate the care of these patients, yet it's proven to be rather elusive. We've not been able to accurately identify which patients are eligible to get risk-adapted therapy. And I will propose and try and show by the end of this that I think liquid biopsies will be an avenue in which we can do that. So I'll start by saying I have no disclosures. Most of the work that we have done at Mount Sinai involves a commercial assay that's by NavDx, and we have a number of research agreements with them. While we are not specifically paid by them, it is important to disclose that we use this specific assay. So, lecture outline. Liquid biopsies are going to be incorporated into the care of many of our patients in the future. And so I wanted to take a little bit of time to give a background on liquid biopsies, talk a little bit about the nomenclature and testing methods, and then in HPV specifically, we'll talk about the applications in diagnosis, applications in surveillance, and then eventually talk about the future with adaptive treatment and minimal residual disease and future directions. So what is a liquid biopsy? I'm not Elizabeth Holmes, and I'm not going to stand up here and make an outlandish claim like you can run hundreds of diagnostic tests on a single drop of blood. I also don't want to go to jail, but I will say that with a 10 ml Streck tube, you can get a lot of information about a patient's potential cancer or the status of their cancer. So a liquid biopsy is a diagnostic test that uses a biologic fluid. So most of what we'll be talking about is blood-based, but you can also have these biomarkers in saliva, CSF, urine, etc. And it's to analyze cellular or molecular biomarkers. The exciting thing about this is while most of us rely on tissue-based diagnoses, those can be invasive and time-consuming and uncomfortable for patients. And if we can get most or all of this information with a liquid biopsy, it can spare the patients the discomfort and also potentially allow for us to get sequential testing throughout their care to be able to provide more accurate real-time information on the status of their cancer. So liquid biopsies in cancer, they really just use our knowledge of what is going on in the cancer environment. So we know that the hallmarks of cancer is that they can grow and then they can spread through lymphatics or through the bloodstream to spread systemically. Also, we know that they oftentimes grow and outgrow their blood supply. And as they do this, they shed some of this debris into the bloodstream. So here you can see an example of various things that you could potentially pick up in the blood. Sometimes you can capture circulating tumor cells as they pass through the blood, although these are infrequent events and quite hard to actually capture, but you can also capture DNA as these cells undergo apoptosis. You can capture RNA, which can give more of a idea of what's going on transcriptionally. And then there are other byproducts like exosomes and extracellular vesicles that are given off as these tumors grow. And the concept of a liquid biopsy is to be able to harbor this information with a blood test. So as I pointed out before, there are a number of different ways in which you can test, and there's various assays, but what I will focus on in this talk is cell-free DNA. This is where the most literature is, especially in the head and neck. So a little bit about the nomenclature, because there's a lot of studies that are coming out and these terms can be used somewhat interchangeably. When DNA is released into the bloodstream, it's called cell-free DNA. So this can be a normal phenomenon or this can be related to a tumor. So if we think about our gut, it's constantly undergoing changes, and that DNA is all throughout the bloodstream. Pregnancy is another classic example of where we have higher levels of DNA, and this would all be cell-free DNA. When it's released from a tumor, you call it circulating tumor DNA. And then in some papers, you'll read when it originates from a virally mediated tumor, such as HPV-associated oropharynx cancer, they'll sometimes call it circulating tumor HPV DNA. Now, if you think about it, there's a lot more cell-free DNA in the bloodstream than circulating tumor DNA. And so you run into a bit of a needle in a haystack problem. You can't just look for DNA in the bloodstream. So how do we determine whether something is cell-free DNA or circulating tumor DNA? Well, and this is applicable more to HPV negative diseases, and that's a little bit beyond the scope of this talk, but you can rely on things like known oncogenic mutations. So things like PTEN, KRAS mutations, they can look for these mutations in the bloodstream, and if they're there, they can use that to track the cancer. There's all these other kind of ways in which they can look at the DNA and determine whether it's coming from a cancer cell or whether it's coming from normal DNA. Fortunately, with HPV oropharynx cancer, we have viral DNA, and I'll explain a little bit more about why that is helpful. So the human genome and the viral genome are sufficiently different. We've all probably seen some schematic that's similar to this. We don't have E6 or E7 proteins, and therefore we shouldn't have E6 or E7 DNA transcripts. And so if those can be picked up, it's a very reliable marker for circulating tumor DNA. Oncogenes are also well conserved in HPV oropharynx cancer with a low mutational burden. So unlike our HPV negative counterparts, where there's multiple mutations that are constantly evolving throughout the care of our patients, oftentimes HPV do not undergo as rapid of mutation, so it's therefore more reliable for longitudinal follow-up. And a common question that I get is HPV DNA from transient infections. So these tend to stay in the epithelial layer, and it's only once you get malignant invasion that it leads to systemic DNA circulation. And so this is why, for instance, in women, you can get a pap smear to test for HPV, but there's not a corresponding blood-based marker for pre-malignant or infectious-based HPV. So finding a needle in this haystack, well, it's a little bit easier when you have viral DNA and better methods of detection. So beyond viral DNA, we over time have been able to pick up these very small fragments with ultra-sensitive methods. So three of the ones that you'll commonly see in the literature are qPCR, droplet digital PCR, and next generation sequencing. And it's over the last few years become apparent that ddPCR and next generation sequencing are really going to be the ones that have enough sensitivity and specificity to be applicable in this space. And this was just a recent systematic review and meta-analysis that looked at these three methods across all HPV cancer types, both oral and cervical and anogenital. And they showed that almost all of them have excellent specificity, but the sensitivity increases, and actually probably next generation sequencing is the best method for high sensitivity. Now, this is a little bit of a busy slide, but I just want to draw your attention. We recently did a systematic review, And if you look here, it's important to recognize when you're analyzing the literature, what type of tests they're using. Are they using qPCR? Are they using next generation sequencing? Because that's going to inform or influence your performance metrics. Also, what primer targets are they looking at? Is it just looking at HPV 16? Now, this will capture 90% of our HPV oropharynx cancers, but 10% are other genotypes. Are they looking at just E6 or are they looking at E6 and E7? All of these will influence the sensitivity and specificity. And then also the time point at which you are testing. Is it pre-treatment, during surveillance, as all of these will influence how the performance metrics behave and therefore our interpretation of the results. So platforms for ctDNA and HPV detection. So there's digital droplet PCR. This is the most commonly used. There's the most literature and platforms. It's also the most affordable. There's numerous proprietary assays, so research assays at different institutions, and there is a commercial assay, NavDX, which is what we use at Sinai. They can be single or multiplex, so they can look for HPV 16, they can look for 18, 33, 35, 45 others, but it's important to recognize that if the genotype is not in the assay, it's not going to be detected. And it can quantify the amount of DNA. So you have copies or fragments, and there's future work that's going to be done to figure out what that actually means in the context of their care. Next generation sequencing, so it has similar specificity, but slightly more sensitivity. It has a higher cost and it's less available. So there's a few proprietary assays. So you may read some elegant articles by Dan Faden at Dana-Farber that uses a next-gen sequencing platform and has excellent performance metrics, but unfortunately it's not widely available. There's fewer commercial assays and there is growing interest, and potentially in the future it will become cost effective to use this type of sequencing for our liquid biopsies. So I'll now that we have a little bit of background on what they are, I'm going to talk a little bit about the applications of these liquid biopsies. So I just want to say that there's kind of three places where we think about liquid biopsies. There's the diagnosis area. So this is pre-treatment patients who are coming into your office. There's in treatment, which is very interesting. Can you use it to risk adapt patients or develop adaptive treatment designs? And then there's surveillance. So looking at patients after their treatment and trying to detect recurrence early. So I'll start by saying HPV oropharynx cancer is not the easiest to reliably detect and confirm the diagnosis. Classically, patients present with a large cystic node and a small primary tumor. Sensitivity of FNA for HPV is around 70 to 80% on the first pass. It's lower if you have a cystic node. And importantly, the tissue yield can often be limited and limit the amount of molecular testing that you can perform, and therefore you may misclassify a patient as HPV negative just because you didn't have an adequate sample. Now, biopsy of the primary site is great, has excellent diagnostic sensitivity. It's great for a tonsil mass, but base of tongue tumors or small tumors can be quite challenging. You have issues with patient comfort, tumor accessibility, delays in scheduling, and the issue of the unknown primary. So patient comes in with a cystic neck mass, but no primary. These can be quite challenging to diagnose and treat. Can a liquid biopsy augment our diagnosis? So this was actually a patient that came to me. They had a right level 2 neck mass. They underwent 2 different biopsies and finally were diagnosed with malignant squamous cell carcinoma. I know this is probably impossible to read on your screens, but it's notable that the P16 or a surrogate marker for HPV was negative, and this patient was told that they had an HPV negative oropharynx cancer and that they needed chemoradiation. The patient was quite distraught. They were a never smoker. They were quite young. Came to me and said to him, this doesn't make sense. I'm guessing you do have HPV positive oropharynx cancer. And sure enough, we got a liquid biopsy and it showed that it was not only positive for HPV, but it was HPV 16, and he may be eligible for a de-escalation trial. So you can see here how at another institution, he may have gotten a radically different treatment. So we looked at our own institutional experience with patients coming in, 163 patients presenting with oropharynx cancer, and we tested this commercial assay on those patients. We found that it had good sensitivity, so about 91% of patients were accurately diagnosed, and notably, it did have 100% specificity in this analysis. So excellent specificity, but 1 in 10 liquid biopsies were a false negative. So it's important to recognize that while these can help augment our diagnosis, they're not perfectly reliable. It's not always the same as a tissue diagnosis. And I do want to note that an updated institutional experience has shown that the specificity is about 96%. We did have one false positive recently. And this is mirrored in the literature. So there was a meta-analysis looking at specifically ddPCR, not next generation sequencing or qPCR, and they found that the pooled sensitivity was about 90% and the specificity was 94%. I know this is a busy slide, but I just want to point out that if you look at this forest plot, the sensitivity is influenced by what they're actually testing for, and usually the year in which it was performed. Earlier assays did not perform as well as more modern or newer assays, and I'm sure in 5 years these data will be also outdated. Other important things is that it can provide genotype specific data. So a recent study came out of the UK showing that there's about a 11% discordance rate between P16 positivity and HPV positivity. So P16 has been an accepted surrogate marker for HPV positivity, but it won't always reliably or accurately diagnose a patient as truly being HPV positive. And they showed in a study that if you're P16 positive and HPV positive, confirmed on either PCR or in situ hybridization, that they did the best. If there was a discordance between the two, they had an intermediate overall survival. And if both were negative, they behaved like a classic HPV negative oropharynx cancer and had the worst overall survival. So with the help of our pathologist, we had 141 patients that had HPV or pharynx cancer confirmed with rigorous testing. So they had P16 testing, they had DNA tested with PCR, and then they tested the RNA with in situ hybridization. The genotypes that were reported with the ddPCR were HPV 16, a majority of the cases, and you can see here the others with decreasing frequency. Notably, there was 100% concordance with the other methods of genotyping. So if the ddPCR tells you it's HPV 16, the other methods should show that. There were 12 false negatives, similarly in this cohort. 4 cases were detected on in situ hybridization for RNA, but weren't on traditional PCR methods. And also 2 cases were genotypes that aren't tested for in the assay. They were 39 and 82. And so it just highlights that, it's not a perfect assay, but neither are our current methods for detecting HPV in tissue. Now, switching gears a little bit, how can this help us with patients who are coming into our office? There's a recent adult neck mass position statement, and it shows that patients who have risk factors, if they have a non-diagnostic biopsy or there's a cystic neck mass, that you should really follow this up. And I'm sure we've all had patients who have come into our office who are between 40 and 60, and they're saying, hey, I think I have a brachial cleft cyst in my neck. And you're sitting there thinking, I'm guessing this is an HPV positive oropharynx cancer. It's a lot to talk to a patient and take them from a benign diagnosis to a cancerous diagnosis and go through all the things that you're going to need to do in order to secure that diagnosis. But could a liquid biopsy help us? So we performed a study, a prospective cohort study with 126 patients presenting with a lateral neck mass. 47 of these were eventually diagnosed with HPV oropharynx cancer. In FNA on those 47 patients, there was 76% or 77% sensitivity. There were 10 false negatives. So whether it was a cystic neck mass or just a neck mass that they weren't able to accurately diagnose, it was wrong about 10% of the time, or 10 cases. Notably, on those that were positive, all of them were HPV-associated oropharynx cancer. ctDNA, on the other hand, there was 95% sensitivity, and there was 97% specificity. So there were 2 false negatives and 2 false positives. I do want to bring your attention to the false positives because it has to do a little bit with how we designed the study, and a little bit of something to understand about the testing. So one of the false positives was a patient who had a very high score fragment level, and their FNA indicated a poorly differentiated squamous cell carcinoma, and the P16 was positive. This was, in all honesty, likely an HPV oropharynx cancer. However, we in our protocol had designated molecular testing or high-risk HPV, either PCR or ISH, as the true gold standard, and the ISH was negative. And so this was counted as a false positive in this study. Probably it was actually a true positive. The other thing is there was a patient with a low or intermediate score, and they were found to have a B-cell lymphoma. And interestingly, on that lymphoma, HPV PCR testing was indeterminate. But this does raise a point about this test. It is not specific to this specific subsite. So not all of these that are positive are going to be coming from the oropharynx. It could be coming from the anogenital tract or cervical. It could also be coming elsewhere in the head and neck. So 2 to 40% of non-oropharyngeal cancers are HPV positive. Now, we know that a high proportion of larynx and hypopharynx tumors are HPV positive, and similarly with nasal cavity and paranasal sinuses. Now, it's not prognostic outside of the oropharynx, but could this be used for diagnosis and surveillance of these patients? This is an area where there's emerging work, but there's been some work out of Dan Faden's lab up in at Harvard, and we showed this in one of our cases, and we have a case series coming out looking at it for sinonasal tumors. So takeaways from diagnosis: excellent sensitivity and specificity, and therefore may have an adjunctive role in securing a diagnosis. Important to understand that different assays have different sensitivities and specificities. It may be particularly useful in the context of an unknown primary tumor or a cystic neck mass, and it provides reliable genotype-specific data. So you can appropriately screen patients for de-escalation trial eligibility. There's some emerging data that shows that HPV-16 has a favorable prognosis, but it might not apply to other high-risk HPV types. And so potentially in the future, we'll see that you really only want to enroll HPV-16 positive patients in these clinical trials. I will caution you, there is a risk of false positives, although it's low. This is not yet adequate for a definitive diagnosis and therefore treatment decisions. So it can aid or augment your treatment decisions, but it should not be the sole determination of how you're going to treat a patient. So what about in surveillance? So our NCCN guidelines are rather vague. They tell us to perform a clinical or fiber optic exam every 1 to 3 months with decreasing frequency thereafter. There's a PET CT scan at 3 months to establish baseline treatment efficacy, but there's a lot of heterogeneity in how we do it. And I also think it's quite interesting that I can have an oral cavity T4N3B cancer that has a terrible prognosis, less than 50% survival, and I surveil them in the exact same way as a T1N0 HPV positive oropharynx cancer that has a 95% survival. The one thing that has the most evidence for use in surveillance is a PET CT at 3 months. And while the negative predictive value is quite good, the positive predictive value is actually quite poor, especially in local recurrences and nodal recurrence. It's quite good for distant mets, but we've just undergone a lot of surgery or chemoradiation that's going to lead to changes that can be misleading on a positive PET scan. Can a liquid biopsy augment our surveillance? So this was a study out of Europe, and I think it's quite nice. So they looked at 66 patients, and 24 of them had an indeterminate finding at their 12-week PET scan. It showed whether they were concerned about the primary site or a node, and they correlated it with those that had cell-free DNA or circulating tumor DNA. Most of these patients actually went on based on or a lot of these patients went on to get some sort of neck dissection or biopsy, and almost all of those that there was radiographic findings, but a negative ctDNA, those all came back negative. Now, if there was a positive concern on the PET scan or CT scan, and this was positive, almost all of them did have some sort of recurrence. It should be notable that there was one where there was no concern and there was still a positive ctDNA at 3 months, and that patient currently has no evidence of disease. Again, not perfect, but it is potentially better than our current standards. And there's not just diagnostic uncertainty at 3 months. We've all had patients who develop ulcers or slowly resolving ulcers after chemoradiation, and we're constantly wondering, is this a recurrence or is this just resolving treatment effect? They have new neck pain. Is that scarring? Is that nodule just scar tissue, or is that actually a node? And so there's actually quite a bit of uncertainty throughout our surveillance. So we looked at and we pulled with 7 other institutions our data on 543 patients, and we found that 210 patients, or 40% of them, had some diagnostic uncertainty at some point during surveillance. And this also shows over here that over time, that diagnostic uncertainty becomes less pervasive, which makes sense. Usually around 3 to 6 months is when we have the most concern about our findings. There were about 81 patients that had concordant liquid biopsy testing while there was a indeterminate finding, and we found that the ctDNA testing correctly predicted the presence or absence of disease in 97.5% of the cases. So you're taking patients who already have uncertainty, or physicians who have uncertainty about the status of their patient, and helping direct them. Now, it should again be noted that there were 2 negative cases that did go on to have a recurrence. We also similarly looked at our own institutional experience with it throughout surveillance, and we found that there was excellent sensitivity and specificity. And importantly, we found that the median lead time from a positive test to pathologic confirmation was about 47 days. The range was 0 to 570 days. And so you can imagine there were some patients who had a significant lead time detection. One patient had a 1.5 years where their test was positive before we were able to find it. I remember this case well because we kept getting PET scans, and we ultimately found that he had a met to his kidney, which was being hidden because the radio tracer was getting excreted by the kidneys, and it wasn't until it was large enough volume that we could pick it up. We've now gone back with our radiologists, and we've started to implement that we communicate with them when the test turns positive, because they do say if they knew this information, they may have picked up that recurrence a little bit earlier. I will also note that in an updated institutional cohort analysis, that there is now a specificity of 98.8%. We have had 2 false positives. We similarly collaborated with a number of other institutions, and we again showed that during surveillance, there's excellent sensitivity and specificity, as well as positive and negative predictive values. Now, these are all retrospective analyses, and so they're prone to biases. There's a nice paper that came out of Europe just earlier this year, where they prospectively enrolled 114 patients. In 11 patients developed a recurrence during their surveillance. 10 of the 11 did turn positive on their liquid biopsy at the time or before the recurrence. They do also note that 3 were symptomatic at the time of detection, so you could make an argument, did the liquid biopsy really aid in the diagnosis? But 8 were asymptomatic. And so they do say that they went on to find these about 40 days on average after, but if they're asymptomatic, who knows how long this could have been going on before it was detected without a liquid biopsy. And all of our surveillance is predicated on the idea that earlier detection will lead to improved outcomes. And so the idea is that if we can be detecting these earlier, then we can hopefully improve the survival of our patients. Now, we don't have data that's able to show that yet, but hopefully that will come in the future. So takeaways from surveillance. During surveillance, it similarly demonstrates excellent performance metrics and may augment correct determination of disease status. It may be particularly useful in the context of a clinically indeterminate finding. And I think the important future directions are, does it lead to improved survival? Is there a threshold for treating without a confirmed tissue biopsy? In that patient that's waiting 577 days, is there a threshold at which we could have started something like immunotherapy to try and improve their overall survival? In personalizing surveillance, can we reduce the frequency of visits? Does the patient need to come in every 3 months for a clinical exam and scope, or can we space it out if they have good pathologic features and their ctDNA is negative? Can we avoid unnecessary procedures where we're doing FNAs of a lymph node that was lighting up on a PET scan at 3 months? And I think the real holy grail of using a liquid biopsy is adaptive treatment, or the idea of minimal residual disease after treatment. So this study came out in the New England Journal of Medicine, and this is not in the head and neck space. It's actually in colon cancer, but it was the first major trial that I know of that showed that a ctDNA guided approach for the treatment of stage 2 colon cancer reduced the need for adjuvant chemotherapy without reducing or compromising recurrence-free survival. So a couple things that are notable about this: they weren't looking at all stages of disease. They were looking specifically at stage 2, where there was controversy about whether to give chemotherapy after surgical resection. They would look at certain pathologic features to try and determine whether someone would get chemotherapy or not, but they didn't find that there were any reliable biomarkers, either clinically or pathologically. And they incorporated ctDNA, and if it stayed positive after their surgery, they went on to get chemotherapy. And if it went to negative, they actually withheld adjuvant chemotherapy. And in that study, they showed that actually there was a slight increase in survival. And like I said, fewer patients actually needed chemotherapy. And this sounds very similar to what we run into with HPV oropharynx cancer. We have patient population that has anywhere from 80 to 90% overall survival. And we don't have good clinical or pathologic features that can reliably determine whether someone needs adjuvant radiation or chemoradiation. This is why, there's, after 15 years, been only one study, ECOG 3311, that's shown that you can safely de-escalate therapy in surgically treated patients. And maybe that's because you're taking patients to surgery and actually accurately pathologically staging them. You're getting things like PNI, you're getting things like LVI, you're picking up microscopic E&E, which may be risk factors. All the efforts to de-escalate patients non-surgically, where you're just relying on our basic clinical and radiographic imaging, we've not been able to safely de-escalate them, as evidenced in HN002 and HN005. So could we use this for adaptive treatment? So there was a study in 2019, a cohort of 103 patients who were treated with chemoradiation. They showed that if you had rapid clearance of the circulating tumor DNA by week 4, it predicted likelihood of disease control. So what I'd like to point out here is if you look over on the left, whether your clinical risk was low or high, if you had a favorable clearance profile none of those patients had a recurrence. If a patient was low risk but had an unfavorable clearance, they had an intermediate risk of recurrence-free survival. And if they were high risk and they had unfavorable clearance profiles, they performed the worst. And so now it wasn't specifically designed to look at this, and they didn't adapt their treatment based on this, but you can start to see maybe there is something here that we can pick up to determine who is safe to de-escalate and who should be going on to get full dose therapy. What about in surgery? UNC and Mayo Clinic in 2021 looked at pre and post surgical resection prior to getting adjuvant therapy. 94% had a positive pre-op value, and of those, 41% remained positive post-op. If you went to negative, all of those patients, negative post-op, all of those patients had no recurrences. So 100% recurrence-free survival, regardless of what adjuvant therapy they got. If it was positive, 83% of those patients did have a recurrence. So if you look here, again, pre-op, they're positive. If it goes to 0 and then they get standard of care, then have they did not have any recurrences. If it stayed positive, your risk of recurrence-free survival goes down. And so again, these are patients who are getting standard of care or care not changed based on these numbers, but you can start to see a pattern here of maybe this is a little bit more sensitive for who is higher risk. And another concept is induction regimens. So there was a trial out of Chicago where they gave patients neoadjuvant chemo immunotherapy followed by response-adapted treatment for HPV oropharynx cancer. And they showed that clearance of ctDNA after neoadjuvant strongly predicted survival outcomes. So if you look over here on this graph, you have HPV copy numbers, and so they start positive, and if they go to 0 before they would start their standard of care treatment or their risk-adapted treatment, if they were undetectable at that point, their survival probability was excellent. If they stayed positive, their survival probability dropped considerably. And they showed that if you look here, they're looking at classic RECIST criteria or imaging features after getting neoadjuvant, and you can see that those don't correlate as well as potentially a liquid biopsy. And so how can we integrate this in the future to determine who is safe for de-escalation? Now, it's important to recognize that there is a lower limit of detection. It's not perfect. So Sloan Kettering did a prospective trial, and this made a lot of waves in the field when they presented an abstract about 2 years ago where they showed that post-op patients with they did a study in post-op patients with indications for adjuvant therapy. So these are patients who got surgery and in standard of care would have gotten either radiation or chemoradiation, and they radically said they would do observation if their ctDNA levels went to undetectable post-operatively. So they enrolled 12 patients. They actually had 14, but 2 were excluded because their post-op values never went to 0. Of those 12, 1 eventually had ctDNA that went up and they gave them radiation afterwards, but never had a pathologically diagnosed recurrence. 3 did develop a recurrence, but 8 continued on active surveillance and are still at this time, to my knowledge, without evidence of disease. It closed early to accrual because it failed to meet a safety for continuation. I just want to point out here that a negative test does not equal no disease. It just means it's below the level of detection of the assay. You could imagine if there's 2 or 3 cells that remain behind, that's going to go on to cause a cancer to recur, but it might not be enough for someone to be able to pick it up in the bloodstream right after surgery. And so it's to say that you can use this information, but it shouldn't be a binary thing in how we adapt our therapy. It might eventually be something like PNI or LVI, positive margins, or E&E, where it helps inform who can be safely de-escalated and who can't be de-escalated. And it's also important to note that 66% of these patients were spared adjuvant therapy. We kind of forget that 8 of these patients should have been getting adjuvant therapy and they have no evidence of disease. And so this might help some of these patients. So the other concept is minimal residual disease after treatment. So you complete your treatment, and can we help risk stratify who's going to go on to have a recurrence before they start their surveillance? So we pulled our data with a number of other institutions, and we looked at the detectability of circulating tumor DNA within the first 3 months following initial or salvage treatment. There was 85% sensitivity and around 99% specificity. If you look here, if they were MRD negative or their test was negative within 3 months after the completion of treatment, these patients did excellent. If they were positive during that time period, as you can see here, a lot of them went on to have a recurrence. RFS, or recurrence-free survival, is radically different if the minimal residual disease testing is positive versus negative. It's important to realize that the clearance rates are different if they had surgery or chemoradiation. So if you do an ablative surgery, the half-life of ctDNA should be about 30 minutes. So within 24 to 48 hours, it should have cleared. If you get chemoradiation, now this is a slower process. Cells are undergoing apoptosis up to 3 months out, and it's likely longer for chemoradiation. So the optimal timing of testing for minimal residual disease is probably going to depend on treatment type and has not yet been defined, but it'll be interesting to look in the future at when you can time this testing to figure out who's at high risk for a recurrence. And the next question is, what do we do with those patients? Well, there's novel therapies coming out like tumor vaccines and immunotherapy, and maybe we could start giving those to these higher risk patients. A lot of the data that I've presented so far is retrospective data, and there's obviously a lot of bias in that. But prospective data is coming. There's a lot of very interesting trials out there that I think in the next 5 or 10 years are really going to fundamentally change the way in which we perform care and think about these liquid biopsies. And I will just give a shout out to our own trial where we have a trial incorporating ctDNA for classically risk features that are questionable. If someone has more than one node, traditionally they should get radiation, but we've expanded that to up to 4 nodes, or if they have less than 2 millimeters of E&E and low risk PNI and LVI, if their values go to 0 afterwards, can we safely de-escalate those patients? Now, it should be noted that if they have 4+ nodes, they have E&E, they have positive margins, but their values go to 0, we are still giving those patients chemoradiation, but we're giving them a lower dose. So again, incorporating that idea that there is a limit of detection, and these other established risk features should not be negated just because we have these liquid biopsy results. I'll just finish with some nuances of test interpretation. So if someone has a negative test, what does that mean? So they could have a true negative, they could have no HPV associated tumor. It could be that the tumor genotype is not tested for. It depends on whether you had a single versus a multiplex assay. There could be a mutation in the primer probe. So not all cancers integrate in the same way and can undergo additional mutations. So this is why someone might be positive preoperatively, but go to negative and undetectable afterwards. Maybe as this tumor is recurring or going systemically, it's undergoing further mutations that aren't picked up by the assay. It could be that there's low shedding of the DNA, no apoptosis or necrosis. There's lower levels of shedding that's below the level of detection. Someone once pointed out that any recurrence that happens in the first 5 years is actually really just a persistence of disease that was below what we could detect. If someone has a cancer recur at 4 years, we don't say that's a new primary, we say that's a recurrence. And so with our standard methods, we're not accurately able to capture that. And similarly, liquid biopsies aren't perfect, and there might be a threshold at which that can be picked up. And there could be technical errors. You might not do an adequate blood draw, and there could be a machine error. interpreting a positive result. Could be a true positive, and you need to go and find that tumor. There could be a lead time detection issue. In our own cohort, we had that case where there was a lead time of 507 days. And it's possible that a current false positive will prove to be a true positive in the future. It could be another location of HPV-associated disease. It could be an anogenital or cervical, or it could be another head and neck subsite. The other question that's very interesting is, especially in surveillance, some people will see a transient spike in your ctDNA, and it could be that the host immune system is actually recognizing it and destroying a small volume of disease. This is the same concept of why unknown primaries might exist. And it, again, could be a false positive. I think I'm at time, so I'm not going to go through this, but it was an illustrative case of how we could use it in care. But I will end with saying that liquid biopsies have the potential to provide an understanding of the temporal heterogeneity of cancer, aiding in precision oncology and earlier detection of disease. It's particularly uh, in HPV positive oropharynx cancer may represent an ideal biomarker given its accessibility, detectability, and excellent performance metrics. And future prospective studies integrating ctDNA into diagnosis, treatment, and monitoring protocols are needed to garner more widespread acceptance and appropriate utilization. With that, I thank you all for listening, and we'll take any questions.
Thank you so much, Dr. If that was beautifully presented. I loved how you organized how that assay is incorporated into kind of each phase of, diagnosis, surveillance, and adaptive treatment. I'm going to officially end ground rounds now, just to allow people who have to sign up for Tumor Board and
Oh,
Rhinology Case Conference to go. But for those that are able to stay on, if you're able to, Dr. Roof, and we have time for a couple of questions, I'm sure we have a couple of questions we'd love to run by you if you have some time.
I'm happy to stay. I apologize that I may have run a little bit long, but happy to entertain any
Oh,
questions.
don't apologize at all. That was really great. I was hoping to kick us off with the questions, if you don't mind.
Yeah,
The summary takeaways were very helpful because I think as a resident, sometimes you'll be in clinic and you'll have somebody who has a positive NAVDX result, but no other sign, and then you're kind of tasked like, how do you counsel a patient with that result?
yeah,
What do you think about in terms of like the follow-up imaging? It sounds like PET is incorporated, but how does the cyanite team do it? And then how
yeah,
frequently do you follow the patient up and how far do you get NAVDX testing? Your point about communicating with radiologists was actually very helpful,
yep.
especially in that positive test. But kind of could you talk more about the Sine algorithm and approach?
Yeah, so this has been an evolving area, and it's a great question because what do you do with that patient where you're suspecting that they have a recurrence, but you don't yet know where it is, and you don't want to potentially expose them to toxic therapy without an actual target. So what we do is if they have a positive test and we reflexively get them a PET CT scan, clinical exam, and fiber optic scope. If we don't find anything, then we'll repeat the test about a month to 6 weeks later, and we'll look to see if it is also still positive. If they do have two positive tests, then we're pretty sure that it's somewhere. Um, what we've been doing is at 3 months, then we'll get another test. And if it is rising, then we will actually get another PET CT scan. Now, I didn't have time to go into it, and this is just truly my thoughts on it, but we have noticed that a lot of patients will hang out in the low teens or below 100 for a long period of time. And then at some point, they will start to have this doubling of their ctDNA. And it's usually when we start to see that doubling of the ctDNA that we're able to actually find something on imaging. But it is a great question about cost effectiveness as at the current time, you can imagine if these turn positive and you're getting a PET CT scan every 3 months, that's not exactly a cost-effective way of doing it. And so I think what you're getting at is how can we reliably use this to then uh, find the optimal time for doing imaging? And we found that it's around that doubling time.
Got it. That's super helpful. Yeah, I can imagine if there's that kind of lag time where you're having the positive ctDNA test, but it hasn't really doubled enough where you kind of have that It's almost as if like the immune system, if that theory is correct, and kind of fighting off the tumor, like is that maybe the time, the juncture where we need to introduce that therapy?
Yes, I will preface that
Apology
this is
question.
all theory,
Yeah,
but that's our presumption is that it's small. The immune system is probably keeping it at bay, and at some point it becomes um, the growth, it becomes visible.
great. I'll open it up to see if anybody else has other questions. The caveat that some of our head neck team might be on tumor board already, but if anybody has other questions, I'm sure Dr. Roof would be able to answer. Okay, Dr. Roof, thank you so much. Really, really grateful for your talk. It was particularly helpful from the resident perspective to just have that overview. We loved having you here. Thank you again. It was really,
Yeah,
really helpful.
of course. And look, more is going to come out in this field, and I think in the next 5 years, how we care for our patients will hopefully be radically different in a positive way.
Yeah. Thank you, Doctor.
All right.
Thank you so much. Have a great day.
You as well.